From the American Academy of Pediatrics.
The death of someone close to a child can have a profound effect with both short and long-term reactions.
It's important for pediatricians to acknowledge grief and make space for it.
When we bring up the topic and someone starts crying, they're not crying because of our question. All they're doing is really showing us the distress they had beforehand, and you need to recognize that's the first step.
Plus, a longitudinal study in the journal Pediatrics shows the effects housing insecurity has on children and teens.
Adolescents in both groups experienced worse self-reported health and also higher depressive symptoms than adolescents who had purely secure housing.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians, for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about how to support a grieving child.
My grandmother died when I was in middle school. The pain of that loss has dulled, but the last thing we ever did together was decorate a Christmas tree, and so every holiday season, I think about her.
Oh, Joanna, that really resonates for me. My grandmother died on Christmas Day when I was 13 years old, just as we were leaving her apartment after celebrating. It's interesting that after so many years, you can still feel so much for a person who's died. And when you lose them when you're a child, that's a lot of time spent grieving.
Death is hard to talk about, so I think we as pediatricians could really use the time and space to work on how we communicate about death with our patients.
Well, there is a pediatrician who thinks a lot about bereavement. He joined us back in 2021 to talk about active shooter drills in schools. Today, he's back to talk about a clinical report in pediatrics supporting the grieving child and family. Dr. David Schonfeld.
Dr. Schonfeld is director of the National Center for School Crisis and Bereavement at Children's Hospital Los Angeles and is a professor of clinical pediatrics at the Keck School of Medicine. Dr. Schonfeld, welcome back to the show.
It's good to be back.
So, David, when the subject of death comes up, people might start crying or even shut down. And so why is it important to bring this topic up when a child's loved one has died and they're in clinic with us?
Well, first off, we need to recognize that when we bring up the topic and someone starts crying, they're not crying because of our question. All they're doing is really showing us the distress they had beforehand. And you need to recognize that's the first step for helping them cope with those feelings, is to give them an opportunity to express them. So some of it is you have to kind of lean into the discomfort and realize that you can help them in very important ways to cope with something that's difficult if you allow yourself to witness some of their distress.
Does every child need to talk about their grief to process it?
Well, I think children do need to talk about it with someone. They don't necessarily need to talk with their pediatrician. They don't need to necessarily talk with a clinician, but they should talk with someone. So I do think it's useful for a pediatrician to make sure there's someone there that the child feels comfortable talking with, who also feels comfortable having that conversation. It doesn't have to be part of every exam that a pediatrician does. I don't think that's practical. But I do think we want to make sure someone is talking to the child. It's a confusing and important and difficult experience. And so someone should help guide the child through that. We don't want children to grieve alone.
I think a lot of us hesitate to bring these issues up with patients because we're worried we're going to do it wrong. When we're seeing a patient who's had a close caregiver or friend or family member die, what are some ways we can bring up that death and then leave space for them to talk about it?
Well, first off, I think you need to realize that you probably won't say the perfect thing every time, and that's okay. Children are quite forgiving if you say something and you're well-intentioned and you're trying to help and it just misses the mark. I've done that with my own kids. So I'll give you an example of once when I did this with my daughter. It wasn't around death, but it was similar, where she looked upset. I asked her what was bothering her, and she said, "I'm depressed." And I looked at her and I said, "Well, you're not depressed." And she said, "How do you know I'm not depressed?" And I said, "Well, I guess I don't really know that. Maybe what I meant was it would bother me if you were depressed." And she said, "It bothers me that I'm depressed too, But if you want to help me, then I need to talk to you about it. But if that's going to cause you too much discomfort, I won't do it, but then you won't be able to help, and you offer to help. And I said, okay, you're right. It would bother me if you were depressed, but it would bother me more if I didn't know about that and I missed the opportunity to help you. So then she looked at me and she said, well, I'm not clinically depressed. And I really wanted to say that was exactly what I meant. But I realized that that would prove that I was right, but I was really more wrong than I was right. So I just said, well, I'm glad to hear that. But if that ever does happen, we've both learned it's important that you share that information with me, because that's what I really want to help you with. And then she went on. She had an argument or disagreement with a friend, and it wasn't a big issue, and she was able to handle it by herself. But I thought, that was a mistake I made. I didn't say the right thing. So I always tell people, don't minimize their distress when someone's grieving. Don't try and cheer them up. Don't tell them that they shouldn't or don't feel that way. But I did the same thing. So I think the main thing that I try and tell people to start with is you don't have to be perfect in what you say. You just have to show that you care. And you can always apologize or correct yourself if you didn't say it perfectly at first. But if you say nothing, that communicates a lot to children, and it leaves them to grieve alone.
But this is still something that's really difficult to talk about. So what are some ways you can bring up the topic without re-traumatizing the child when you're talking to them?
So I think you can start with just open-ended questions. You might say, I understand that your mother died. How have you and your family been doing since that's happened? Or can you tell me a little bit more about how you've been coping with the death of your brother? So I would start first with open-ended questions and then take it from there. But a lot of what you really want to do is active listening. It's not so much what you say, it's that you start the conversation and then you step back and you listen. And so there's a really nice metaphor that an educator gave me when I was interviewing her. And she talked about the fact that a student had come back to class after the death of his mother. And she started to ask him about what happened and how he was doing. And I think it was in front of the class. So he got embarrassed and he said, please don't do this. So she said, okay, but my door's open. It's always open. You can come and talk to me whenever you're ready. But he didn't come and talk to her about his grief. Instead, several weeks later, he stopped by just to thank her. And she said, what are you thanking me for? And he said, you were there and I didn't have to talk about it. And she said, it's kind of like a dance. I take the first step. If the student's ready and he takes the next step, fine, we continue the dance. If not, that's okay. We can just stop and listen to the music together. I thought it was a really nice metaphor. So a lot of what it is that you're an empathic presence. You're there with a child who's grieving. You witness it. And you hold space for them and you say, it's okay for you to tell me about this. I'm here. How can I support you? So I think we often feel that there's something you're supposed to be able to say that makes this okay. And I guess I've done this work for a long time and I realize there's nothing I can say that's going to make this okay for someone who's grieving. I can just share that experience with them. You can say things like, with time, you will likely find that this will become easier, but right now I understand it's really difficult for you. So you can convey a positive future perspective, but you don't want to say something like, well, at least he's not in pain anymore. Or I know your mother died, but at least your father's with you. You don't want to try and minimize it. If you're going to say something that starts with at least, why don't you reconsider it and think about it before you make that comment? So a lot of it is just being present and starting the conversation. I think also you can make observations as long as you convey them in a way that's non-judgmental. So you could, for example, if a patient is in your practice and you've seen them a number of times, you could say, I've noticed that ever since your mother died, you're more quiet when you come and visit with me. Can you tell me how are you doing? But if you say instead, ever since your mother died, you're not participating enough in our visit, so I don't get a good sense of what you need, that sounds judgmental. So I think you can make observations as long as your observations are not judgmental. I will say, by the way, I think this is just good advice in general, even if the child isn't grieving, is to make your observations in ways that don't seem judgmental. But I think it's particularly important when they're grieving.
I love that advice. As pediatricians, we're always thinking developmentally. Is there an age at which it's too early to address how a child is coping with a death? faith in somebody that they care about? Or what is the best way to approach this with younger kids?
Okay. So the short answer would be no, there isn't an age that's too early. Even infants respond to deaths of important family members even before they're able to understand what death is or exactly what's occurred in the family. We know that infants, for example, will respond with altered feeding patterns and changes in weight gain when there's been a serious illness or death of a sibling, for example, even though they don't understand exactly what's happening. But starting at about 6 to 9 months of age, children develop object permanence, or they start to develop it at that point. Once they start to develop object permanence, they can experience permanent loss, which is what is involved in grief and in bereavement. So from that point on, children start to grieve. It's interesting that in cultures across the world, you do see that children start to play the same game at about 6 to 9 months of age, which has to do with their growing perception of object permanence and their worry about permanent loss. In the United States, we call it peekaboo. And in peekaboo, the child fixes their gaze on someone. There's then separation as if the person has died, heightened concern and awareness on the part of the child, and then a joy at reunion. And they play it over and over again. So you always should ask yourself as a pediatrician, if children play the same game at the same developmental period in cultures across the world, why are they doing that? Because they seem almost driven to do it. You can play peekaboo with almost any 6 to 9 month old anywhere in the world, and you will have their attention. And so people have said it's one of the first games about death. And actually, peekaboo is Old English and translates literally into alive or dead. So that's what the game is about. So starting at that age, children start to think about it, and they engage adults in conversations about it, even though the adults don't know that's what the conversation is about. And then children continue to have interest in this. So I've actually explained the death of a family member to children below 2 years of age, and some of them have understood it. So I think you want to support a child who is in a family situation where there's been a death, even if you're not sure they're grieving yet. And if they are grieving and showing distress, you want to provide support, even if they're not able to understand the concepts fully. But most children learn the concept somewhere between 5 to 7 years of age, even in the absence of education or personal experience. But personal experience tends to accelerate the rate that they acquire those concepts.
I once heard death described as crossing the rainbow bridge. Do these types of colorful euphemisms work to make death easier to understand or comprehend for young children?
Well, actually, most of the euphemisms are not intended to help children understand it. They're actually intended to decrease their comprehension. That's why it feels better, is because you're not really explaining it to them. So that just leads to confusion and difficulty with adjustment. I think analogies may be used to help children understand difficult concepts, but the euphemisms actually obscure the understanding. That's their purpose. So I think that sometimes we present explanations to children that are too advanced, they're too abstract, and they cause actual problems with children. I had one child who his brother died of SIDS, sudden infant death syndrome, and his parents told him that his brother was such a good little baby, God wanted him back at his side as an angel. So the child made it very clear without any discussion that whenever he went to God's home, which was church, he was going to make it very apparent to God that he was an angel potential and he did not wish to be called back. So every Sunday, he misbehaved in church for months. Parents never made the association to what explanation they had given to him until I picked this up in a walk-in clinic when he came in for a stomachache. And I asked questions about, I see his brother died. What happened? And they were annoyed. They hadn't met me before. They didn't think it was relevant. They didn't want to discuss it. And I kept saying, any changes in his sleep? And they were like, no, he's fine. And I said, what about changes in his behavior? And they said, oh, well, he does misbehave in church now. Anyway, we had the conversation. Remember, they looked at me and they said, did we really do that to our child? And I'm like, I don't think explanation worked. Like, let's really explain to him what happened to his brother. I think that's what he needs. So I think the euphemisms really run the risk of clouding their understanding. They may then show less distress because that's because they don't really understand what's going on. It's not because they've coped with it.
Wow, I'm just floored by that story. So let's move up in age a little bit. Our adolescent patients certainly are able to think about things in more advanced ways. Does that mean we don't have to worry about them as much?
Adolescence is actually a complicated time to experience the death of a close family member, particularly a parent or caregiver, because it's a time when there's some ambivalence about independence and dependency, and they're trying to forge out on their own. And so it's difficult when kind of your secure base dies. It's one thing to say, I don't want to be here anymore. I want to go to college, or I want to go to the military or pursue a career elsewhere. But you know that your parent is still there. When they die, it's hard to leave at that point. And a lot of adolescents take a lot of responsibility for supporting adult caregivers, particularly after a death has occurred. And so they may actually not even start grieving until they're sure their parent is okay. I had one child that I saw, he was about 16, very mature, empathic young man, and his mother worked as a nurse at the hospital I was at. And an older brother had died in an accident very suddenly. And so she took off about 2 months from work, then came back, and she was back for about another 2 months. And she came to see me and she said, "Can you see my 16-year-old? I'm worried. He was doing fine for about 2 months, but now his grades are dropping. He's feeling depressed. He's having trouble sleeping and concentrating." So he comes in and I asked him, "Well, why do you think you were doing okay for 2 months?" And he said, "I don't know. I was doing okay. And all of a sudden it just hit me." And I looked at him and I said, "Well, sometimes it's hard to see your mother grieve." And he said, "If she cried on my shoulder one more time to fall asleep, I was going to lose it." And so what he was doing was he was supporting his mom. So he didn't have time for his own feelings. He didn't even have time to grieve himself. Now, the dad was supportive and in the home as well, but this 16-year-old adolescent was just a particularly empathic, supportive young man. So his mother was figuratively and literally leaning on him, and it made it impossible for him to start to grieve. So I think we do have to be concerned with adolescents and realize it's a vulnerable time period, particularly if they're going off to college or to their career.
Well, that story for me really brings up the concept of resilience in children. And I still think about my grandmother dying, so I'm not sure if people really ever get over a death. But if kids are surrounded by death, do they get used to it?
Well, if you grow up on a farm and animals die periodically, you do get kind of used to that's the natural order of life. And so from that perspective, you can get used to the experience of death. But when it's a personal loss that's important to you, I don't think you get used to it in the sense that it no longer bothers you. In fact, most children who are exposed to deaths of friends and family members in high numbers are usually not coping with them because they're not given adequate time or resources or supports. So it's just multiply traumatizing them. It's just making it more difficult. That's what we talk about with cumulative loss. So if the losses happen frequently, it doesn't really desensitize you. You don't get used to it. You just get used to the fact that adults aren't really going to help you with it. So you stop asking or seeking that assistance. You don't complain about it necessarily to a teacher in school because you don't expect the teacher to do anything with that information. It means that you really just suffer yourself, or you turn to a peer group, or you turn to other strategies to try and cope that are often less effective. I think it's unrealistic also for people to think they ever get over a significant loss. These are life-changing events. And that's what they do. You're different as a result of having gone through that loss or going through a traumatic experience. We wouldn't want people to forget those that they loved. So it's like if you're a parent and you have one child and that child dies, you're still a parent. You're just a parent of a child who died. You don't go back to never having had children. You don't forget that you had children. They're life-changing events, and that's what they ought to do to people. And so we incorporate it. Now, one of the concerns that I have is that when I talk with pediatricians, a lot of people go into pediatrics because of traumatic or loss experiences in their own childhood or in the childhood of those that they love. And they want to help children because they know how meaningful it is, in part because someone helped them when they were younger or because someone didn't help them in a way they really wanted or could have used. That helps them get what we call post-traumatic growth. And individuals then may become more compassionate, more empathic, more interested in helping others, have a higher purpose in life, maybe more spirituality. The problem is when they then help others who have experienced loss, they're more likely to uncover their memories of their own losses. So professional self-care is important in general, but it's really important in the helping professions because the people who are driven to these helping professions often are the ones that are most likely to be hurt by helping others. So we really need to take care of ourselves because we're empathic and compassionate, because it bothers us more. And we often have more that can come forward because of the reasons why we went into these careers in the first place.
That's a lot to think about. We know developmentally that children often blame themselves for something where they really don't hold any responsibility whatsoever. Is that also the case when it comes to death?
Actually, guilt is extremely common after a death has occurred. Children will wonder what they did, didn't do, should have done, or could have done to prevent it. Part of it is related to the egocentrism of young children. And they may assume that if something bad happened and they feel badly, they did bad. And so it's really important to reassure children that they didn't have a role or responsibility in this. But at some level, this continues into adolescence and adulthood. When someone we care dies, we worry whether someone else we care about is going to die. And if we allow ourselves to kind of adopt what I call an illusion of control, there is something I contributed to, then you can decide you're not going to do that again and therefore prevent or decrease the risk of someone else dying. That illusion of control gives us some control over feeling the anxiety about future loss. The problem is it's an illusion of control, so it doesn't actually work. And it leads the individual with feelings of guilt, which are very difficult to deal with and complicate the grief process. So I've seen this with young kids. I've seen this with their parents, where I've simply said, I know you didn't do anything to cause this, but I wonder if you've ever worried about that. I've had parents start crying and tell me about their guilt feelings that they didn't feel safe sharing with anyone else. But after 35 years of doing this, I have found 2, maybe 3 situations where I didn't find someone who eventually expressed their guilt to me. So it's so common. I think it's really worth the effort of addressing it.
As adults, we often get comfort from spiritual rituals, funerals that help us cope with death. How should children be involved or not involved in these rituals?
Well, I think it's right. They bring comfort. That's the reason why they have continued for generations and generations, is because for most people, they do bring solace and comfort, companionship, and they're ways of learning how to deal with tragic losses. So I think they are equally important to children. But the caveat is, I think we need to explain to children what they are likely to see and experience, not just about the body, but also that there may be relatives telling funny stories. Other people may be crying. I come from a more blended family in terms of religious backgrounds. And so I'd been to a Jewish funeral, but then I was at a Catholic one. And I remember at one point saying to my mother, I wasn't that old, and there was a relative who died, and it was on the kind of more the Sicilian side. And so I was like, there was a woman trying to crawl into the casket. They go, yeah, that was his wife. And I go,
oh my gosh,
she was trying to get in with him. And my mother goes, yeah, that's what they do. That happens. And I'm like, well, what do you do? And she goes, well, people don't let her do it. She's not actually going to do it. And I go, but it was really odd to see. And she was like, yeah, I probably should have told you about that. So the issue is, it was a very different experience for me than going to a funeral where most of the people were Orthodox Jews. So, you want to explain that there are going to be people telling stories. You may be asked to tell a story. You don't need to tell a story. So you want to prepare children and then ask them, would they like to participate? And don't force or coerce them to do anything in particular that they don't want. And I also find it's really helpful to kind of assign a mentor to the child, an adult who knows the child, understands child development, but isn't personally grieving themselves. So it might be a babysitter, a neighbor, a teacher, someone from Boys and Girls Club or other youth group who's there to kind of guide the child through the experience, so that if you sense, I think the child's had enough of this particular experience, then you can say, hey, let's go for a walk. I just wanted to go talk with you. Can we step out? And then ask them, do you want to go back in or do you want to stay here? What would you like to do? But if it's left just to the, say, surviving parent, it's very hard for the kid to even get to the bathroom. Their needs are hard to monitor by someone who is actively grieving and also feels responsibility for trying to support other people in the room. So if you assign a guide or a mentor or support person to children, that I think is particularly helpful. With teenagers, it may be that more they bring a peer or there's someone else that, they have a close friend who can sit with them and help them through that process. But I think we need to explain things to kids. We need to invite them to participate. We shouldn't force or coerce them to do anything. And then we should help them figure out what is it that they may wish to contribute to the ceremony that's developmentally appropriate and not overwhelming for them. It might be that they pick a floral arrangement, or they help identify a song that someone will play or sing that means something to them because it meant something to the person who died. Allow them to help contribute in a way that seems meaningful to them, but not overwhelming.
David, you've made this topic so much easier to talk about, and there's so much more we could say. But do you have any last takeaways for our listeners?
Well, the first thing is to recognize that bereavement has a dramatic impact on children, both short-term and long-term. And pediatricians should see this as part of how they can help and what is important to the well-being of children. So just acknowledging it, telling them that you care, helping to figure out where they're going to get the support, whether it's at home or that the parent knows to talk to the teacher to figure out academic accommodations and supports. Just make sure people are thinking about what might make this easier for a child is a really important intervention that pediatricians are particularly well suited to do.
Dr. David Schonfeld, thank you so much for joining us today.
And thank you for having me here.
To read the new clinical report, Supporting the Grieving Child and Family, visit our website at aap.org/podcast.
Coming up, we'll look at how housing insecurity affects children and teens.
I know you love books, Joanna, so do you have any good summer beach reads I should know about?
Well, this isn't a beach read, really, but you have to read Invisible Child, Poverty, Survival, and Hope in an American City. It's something I think every pediatrician should read, and a major theme in it is housing insecurity.
I haven't read it yet, but with a title like that, I imagine it covers a lot of adverse childhood experiences, and housing insecurity can be a big one for kids. I'll add it to my reading list.
I know we have listeners and not readers, so let's talk about housing insecurity. There's a new article in Pediatrics, Trajectories of Housing Insecurity from Infancy to Adolescence and Adolescent Health Outcomes. And here to help us review this topic is lead author Kristyn Pierce.
Kristyn has a master's in public health and is a biostatistician at the New York University NYU Grossman School of Medicine, working at the Department of Pediatrics. Kristyn, welcome to the show.
Thank you. Excited to be here.
We're excited to have you. And this was a longitudinal study. How did you get data on children from birth to adolescence?
This was a secondary analysis of data from the Future of Families and Child Wellbeing study. Children and birthing parents were enrolled in early 2000 and have now been followed for over 20 years by the researchers. So we were able to use that data for our analysis.
When talking about housing instability, I can imagine it means different things to different people. In terms of your study, how did you define it?
So we used 5 indicators to define housing insecurity, and that was homelessness, eviction, difficulty paying rent or mortgage, doubling up, meaning, more than one family living in the same house or doubling up within the rooms within the house to save room, and also multiple moves. And so you're correct that the experience is very different for everyone because a lot of the people in our study spent multiple nights in a place not meant for residents, but another person maybe was just like had difficulty paying rent. So there's no like one size fits all experience.
And in terms of structuring your study, were these the groups you used or did you combine them?
So using our measure of the 5 indicators, we used group-based trajectory modeling and quantified how housing insecurity fluctuated over time from age 1 to age 15 for the participants in the study. And from the modeling technique, we found 3 groups of housing insecurity from age 1 to age 15 in the sample. And there was a group who experienced no housing insecurity at all. There was a group who had moderate insecurity, which meant that they had low insecurity, but was fluctuating over time. So maybe some spikes or maybe just at one point in time. And then we also had a group of high insecurity where it started high in early childhood and then gradually got better over time.
And before you did the study, what were some of the known health consequences of housing instability for children that you wanted to examine?
So there are direct and indirect impacts of housing insecurity on child health. And the direct ones are, behavioral problems, internalizing and externalizing behaviors. But then they're also affected because the caretaker is also being affected by, the stress of the instability. So the consequences of it are layered.
And what did your study add to what we already know about housing insecurity as an adverse childhood experience?
So our study, because we looked at it as a longitudinal experience rather than at one point in time, we first got to see how children experience housing insecurity, because in the literature, there is a lot of literature about housing insecurity in childhood, but it's just cross-sectional. So are you experiencing housing insecurity and whatever outcome that the study is looking at? But this study actually helped us to see how housing insecurity sort of fluctuates over time in those who experience it. So we can better characterize the experience itself and identify like optimal periods when it's spiking to give us more information about when to intervene or when it's the worst.
And what sorts of impacts did you see from housing insecurity in children as they grew and developed?
So we only looked at outcomes at age 15. And at age 15, adolescents who were in either group of insecurity, so they either experienced this moderate, fluctuating, low housing insecurity from 1 to 15, or they experienced this higher degree of insecurity, which decreased over time. Adolescents in both groups experienced worse self-reported health and also higher depressive symptoms than adolescents who had purely secure housing throughout the duration of the study. And also the adolescents who were in that high insecurity group also had reported more anxiety symptoms at age 15.
And I'm curious, does poverty equate to housing insecurity? What were some of the big risk factors you saw for it when looking at children in this database?
So there was nothing that stuck out as very we can screen for the XYZ sociodemographics and things like that to screen for housing insecurity. It really was all over the board. But some of the differences between the groups: in the secure housing, parents' marital status was different. There were higher degrees of people living below the federal poverty line in the 2 insecure groups, but race and ethnicity was all over the board.
I know this wasn't in the study, but from your experience, are there things that we as pediatricians can do to help address housing insecurity for the families we serve?
I think that it takes a village. I myself am not a pediatrician, so I can't speak to all that goes on in the clinic. But, one big thing that you think about is you can screen as much as you want, and you should be screening. But the other piece of that puzzle is once someone screens positive, what do you do? What resources do you have to offer them? And that takes the help of, policies. You need more affordable housing. You need more protections for families experiencing housing insecurity. I also think that a lot of people are missed in the clinic. Like, if you don't have a secure home base, it's very likely that you're not securely engaged in a medical home. So I think that it will take partnerships with, community health workers, social workers, other people who can screen in other places where you might be able to identify families experiencing housing insecurity.
Those are all great thoughts for pediatricians. And Kristyn, do you have any other takeaways you'd like listeners to know before they go read your paper?
I think that this is very important. And I think that it also, because of the point that I just made, that children, families, whoever experiencing housing insecurity are likely, not all of them are captured in our research that we do in big medical institutions. So I think that this project is not even showing the worst experience. And so we're in dire need of more resources, more efforts, it's really going to take a village. And we see from this project that the consequences are not good and they're long lasting.
Kristyn, this has been so informative, and I want to thank you for joining us today.
Thank you so much.
To read the article, Trajectories of Housing Insecurity from Infancy to Adolescence and Adolescent Health Outcomes, go to our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
I've got a few, but I am going to land on the eastern narrow-mouthed toad.
And smush it?
No, I'm going to try not to smush it. This is an amphibian. I love the critters, right? So This is an amphibian that's native to this area, but I've never seen one before last week when we were walking our dogs at night with flashlights, and I saw these little frog-like things. They actually are frogs. They're misnamed as toads. They have moist skin, but they've got like a little beak-shaped mouth, and they're stripy, and they're super cool looking, and usually they live underground and eat ants, so seeing them is kind of rare, and it's just like, when I meet a new frog, I'm just really happy.
That's so cool, David. I think you're rubbing off on me, actually, because my Say Ah is I was at the beach on the weekend with a friend, kind of visiting and hanging out, and I saw this bird in the sky, and I was like, oh, look at that bird. I'm pretty sure that's an osprey. And she was like, is it? I think it's a seagull. And I was like, no, it's an osprey.
Darn it.
And we watched it dive into the water and grab like a big fish out of the ocean. And I was like, that's it. And I was like so excited about this bird. And then I was like, oh my God, I'm getting old.
We've been working together too long now, Joanna. Welcome to my world.
It's just rubbing off on me, yeah.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer. And Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll learn more about building trauma-informed pediatric practices.
We'll talk to doctors R.J. Gillespie and Amy King about a resilience-based roadmap to foster early relational health. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.